Good afternoon, everyone, and we welcome you all today to this session on videos in anterior segment. And in the interest of the time, I would like to call our first presenting author, Dr. Prabhakar Singh. Is he there?
I'm here. Okay. A very good afternoon.
Everyone, the title of this presentation is Ocular Surface Squamous Neoplasia and its Management. The authors have no financial interests. The learning objectives for this presentation include which lesions are suspicious and how do we support our diagnosis, how do we medically manage these lesions, the indications of surgical management and the technique, and also what complications can we anticipate post-surgery. Coming to our first learning objective, which lesions are suspicious? Any conjunctival lesion adjacent to the limbus or straddling the limbus with a keratinous, plaque-like or gelatinous or papillary consistency with associated dilated tortuous feeder vessels with or without pigmentary changes should raise a suspicion of OSSN. A corneal OSSN can be suspected for any plaque-like lesion over the cornea that is contiguous with the adjacent limbus and gets more pronounced after staining the cornea with fluorescein. In order to clinically confirm our findings, we can use rose Bengal stain to stain the ocular surface. Rose Bengal highlights the entire extent of the lesion over the ocular surface, and even subtle changes over the cornea or the adjacent conjunctiva can be picked up following rose Bengal staining. We can further support our diagnosis with AIOS2025-Videos to demonstrate an abrupt transition in the epithelial layer, suggestive of epithelial hyperplasia, which is very characteristic of OSSN. Our second learning objective is how can we manage OSSN medically. The following are the chemotherapeutic agents in the armamentarium for treating OSSN. The first one is interferon alpha 2B in a concentration of 1 million international units per ml and daily dosing. The second one is 0.04% mitomycin C with 4 days on and 3 days off regimen in a week. And the last one is 1% 5-fluorouracil with 1 week on and 3 weeks off regimen, all of which have been found to be effective. Here are a few examples of OSSN which have been treated with the chemotherapeutic agents discussed before. These are the images of 3 different patients at presentation, and following treatment with the given chemotherapeutic agents over 3 months, they resolved completely. However, the treatment was continued for 1 month beyond the declaration of clinical resolution. After medical management, let us see the indications of surgical excision. Any lesion that is small enough, that is less than 4 clock-hours according to Shields, or up to 5 mm in its greatest dimension according to AJCC, unifocal lesions, and lesions with an uncertain diagnosis can all be managed by a surgical excision. To understand one such scenario, let us go through the case of a 24-year-old male who presented with the given clinical picture for cosmetic reasons. On examination, a mixed lesion with gelatinous and papillary appearance, along with pigmentary changes and straddling 2.5 clock-hours of the limbus with multiple feeder vessels were noted. A provisional diagnosis of OSSN was arrived at. The patient was started on interferon alpha 2B. However, on no response to the given treatment for 6 weeks, and in view of this being a unifocal lesion, the patient was planned for surgical excision along with a conjunctival autograft. Let us now see the surgical technique. A 4 mm border is marked all around the outer boundary of the OSSN on the conjunctival side using calipers and a marking pen. A subconjunctival injection of saline is given underneath the lesion to facilitate dissection. Dissection is now performed along the marks made previously, taking care not to touch or to crush the area of interest. After meticulous dissection along borders on all sides of the OSSN, the lesion is reflected onto the cornea and then cut flush with the limbus using a creasing knife. The lesion is placed on filter paper along with appropriate marking of its boundaries and sent for histopathology. An alcohol soaked swab is placed on the corneal edge of the OSSN, after which epithelial debridement in the given area is completed using a crescent knife. The cut ends of the conjunctiva are treated with cryotherapy with double freeze-thaw technique. Cryotherapy is also applied to the nasal limbus to treat the area of the lesion. Saline is injected under the superotemporal bulbar conjunctiva and a conjunctival autograft is harvested from that area. Using fibrin glue, the conjunctival autograft is glued to the bare sclera. It is ironed out to remove excess glue from underneath. The nasal edge of the graft is opposed to the free conjunctival edge. This is the preoperative picture where we can see the lesion straddling the limbus. 1 month after surgery, this was the clinical scenario where we can see that the lesion has been excised completely and the conjunctival autograft placed over the area has been taken out properly. Coming to our last learning objective, what can be the complications of such a surgery? The first one is iatrogenic damage to the limbal stem cells, which can occur either during the excision of the lesion or can be induced by cryotherapy. The next one is an incomplete excision of the lesion or recurrence of the lesion after excision. Our take-home message from this presentation is the clinical features of a lesion, rose Bengal staining and anterior segment OCT in the area of interest are all reliable methods to come to a diagnosis of OSSN when such a lesion presents to us. Topical therapy is usually the treatment of choice. Surgery is a one-time procedure which does not require long-term treatment. However, wise selection of a case is imperative in such cases. It is also important to assess the risk of any post-surgical complications pre-operative. Thank you.
Excellent talk, Dr. Prabhakar.
Thank you, sir.
Very well. How do you distinguish, management? What are the newer trends in the management from the earlier, the usual way of managing things? What are the newer trends in the last few years in the management of OSSN?
So surgical excision is the gold standard, is still a gold standard treatment or the management option for the OSSN. However, we have seen that over the last few years, we have seen various topical agents that I have discussed, like mitomycin C, interferon alpha 2B, and 5-fluorouracil. These are the topical medications which are now used very often and has been the first choice of most of the treating physicians or the surgeon. And in most of the cases, we have seen that it not only helps in removing the smaller ones, even in cases where there is diffuse involvement, we want chemoreduction first, followed by surgical excision. We can still go ahead and decrease the size of the tumor giving these topical agents. And many times we see we don't even require the surgical excision, rather just with the topical medication, these respond very beautifully.
Important is that we must recognize the condition OSSN, and if we can't manage as a general ophthalmologist, you may refer it to the specialist who is doing it. Thank you very much. And Dr. Vaibhav Nagpal to be the next speaker, to be the next presenter.
Dr. Prabhakar, just a question. Which is your preferred modality for chemoreduction? And why?
So largely it's based on the availability of drug also, because most of the cases we want to start the patient on interferon alpha 2b because of the lesser side effect profile. However, it is not readily available at all the places. So preferably interferon alpha 2b, informing the patient that it will take longer time compared to rest of the medications.
Yes. But
And
between MMC
otherwise, MMC and 5-fluorouracil. So we have recently done a study also where we noted that the resolution time was faster with 5-fluorouracil with more side effect profiles. So that way,
yeah. Thank you, Dr. Prabha.
thank you so much.
Dr.
A stitch in time saves 9. Importance of complete removal of lime particles in chemical injury. You may start.
Acute chemical injury is an ophthalmic emergency. Initial management determines the course of disease. Considering lime injury is one of the commonest chemical injury in our country, we'll be going through two cases highlighting the importance of complete and timely removal of lime particles. 2-year-old female child had a chemical injury 5 days back. Cornea showed large epithelial defect and few areas of limbal ischemia. On doing double eversion, a large plaque was noted superinasally. Multiple lime particles were dissected and removed. For better exposure, a traction suture was used to rotate the globe downwards. After noting the exact extent of the lime plaque and getting adequate exposure, the dissection of the plaque was begun. Careful dissection is necessary. Residual particles cause chronic inflammation which prevent re-epithelialization of cornea and also leads to symblepharon formation. The technique is simple, but it requires a lot of patience and thoroughness to completely remove the whole lime particle in toto. Since the patient presented early, the plaque is limited to subconjunctival space, sparing the underlying sclera, and hence has a better prognosis. After removing the plaque, the whole ocular surface from the upper lid margin to the lower lid margin is covered with an amniotic membrane. The amniotic membrane is secured with absorbable sutures in lower and upper fornices. Bandage contact lens is placed in the end and a temporary lateral tarsorrhaphy is done. After 1 month, we can see that the cornea is completely epithelialized. However, there is a small residual particle near the limbus which will be removed. There is granulation tissue superinasally. but otherwise fornices are deep and the eye is quiet. This is the child 4 months after the intervention with a clear cornea and deep fornices, and at present there is no symblepharon. Unfortunately, the second child was not so lucky, as he presented 45 days after the injury. Child presented to us with a grade 3 contracted socket. After doing inferior peritomy, severe scleral thinning was noted. After dissecting the superior symblepharon, we saw a large lime plaque which was involving the cornea as well as the sclera. Due to the embedded lime particle, the consistency of the cornea as well as the sclera had become very hard. After superior dissection, the posterior extent of this plaque was still not known. As you can see nasally, we tried to lift the plaque, but we encountered the choroidal tissue. Since the normal sclera had completely melted, we left this plaque in situ. We decided to place an amniotic membrane and do an allogenic simple limbal epithelial transplant for a faster reepithelialization of the surface. The amniotic membrane was secured with fibrin glue as well as absorbable sutures. We were lucky to have a corneal tissue available for allogenic stem cell transplantation. The underlying stromal tissue was trimmed and the limbal tissue was divided into small pieces and placed over mid-peripheral cornea and secured with fibrin glue. A central tarsorrhaphy was done to hasten the reepithelialization. Since the lime particle was integrated, we left it in situ. The dissection would have exposed the choroidal tissue, which was not desirable. We have started the child on systemic immunosuppression and awaiting the response. As we saw in the first case, the child presented early and had a good outcome. Unfortunately, the second child had inadequate lime particle removal and led to such a severe sequelae. These cases highlight the crucial role of initial management in such cases.
Very nice presentation, and that again reminds us the importance of why washing immediately after any lime particle chemical injury in the eye is so essential, and even afterwards the management has to be very adequate. Yes, would like to comment.
Dr. Weber, I would like to know any thoughts on EDTA chelation in such cases, especially your second case, where you could not do the complete lime removal?
But the plaque was very big and the superior extent we could not see. So where to put the EDTA and how much we would be able to chelate and remove, that was the point. And there was no normal sclera left. So even if we chelate and we try to remove forcibly, we'll be exposing the choroid and the patient will be going into phthisis. So less likely in such advanced cases, we can go ahead with this management.
Comment? Yeah. So we invite the next speaker, Dr. Afrin Bari, to speak on crescentic autograft graft salvage technique for undersized donor lenticles in SAL. The next speaker is not present. Can we just have who are the speakers present here? Dr. Prabhujot Singh, are you here? Yes, please come on the dais. Dr. Jasriya Idris, are you here? Yes, she's here. Dr. Mohiddin Abdul Qadar, yes, yes. And Dr. Tushya Om Prakash is here. Not here. All right. So, Dr. Afrin Bari.
Dr. Prabhjot.
No, she is not there. Dr. Prabhjot. Yeah, Dr. Prabhjot Singh.
So I'm presenting a video on targeted limbal stem cell transplantation for post-penetrating keratoblastic corneal haze. To give a preview of our study, we enrolled patients with post-penetrating corneal haze, in which cases the haze persisted for more than 3 months after the PK, and there was a visible strep or a ledge or a epithelial discontinuity for more than 50 microns in the epithelium, or there was hyperreflectivity in the cornea around the graft host junction for more than 150 microns. We enrolled 7 such patients in our study. Our hypothesis was that due to this gap, the host epithelium is not able to jump over to the donor epithelium, thereby the persistent corneal haze. So we took 4 such scans, vertical, horizontal, and 2 oblique scans to have the image of 8 graft host junction areas, and we analyzed any irregular defects in such images. Our typical procedure started with as same as a SLED procedure would start. We harvested 2 into 2 mm limbal stem cell lenticule. And then we divided it into 6 to 8 multiple small pieces. The crucial point in our surgery was to reanalyze such areas in intraoperative OCT. You can see on the OCT that there is a typical characteristic step and a defect of more than 50 microns in the epithelium in graft host junction. So we have to precisely target this area with our limbal lenticules. Then we went ahead and took the lenticules and we precisely placed that lenticules into those defects with OCT. You can see the hyperreflective lenticules beautifully sitting into the defects. So this is the first post-op day picture, the lenticule sitting into this defect with overlying BCL. Then a post-op week 1 picture, the defect is continuously healing and the epithelium has started to migrate towards the donor cornea, and there is regeneration of the anterior stoma of the cornea. Post of week 3, the epithelium has almost migrated and there is a continuous, the defect is almost healed and there is a regeneration of the anterior stoma with regeneration of the epithelium. And then by post of week 6, it is a near normal graft host junction. This is the pre-op picture of same patient with persistent corneal haze, and then post of week 6, there is almost clear cornea. To further strengthen the hypothesis of our study, we took a cadaveric cornea and we performed the TLET, that is targeted limbal epithelial transplantation in that cornea. We took limbal lenticule from one quadrant and we created the multiple lenticules from that 2 mm lenticule. And then we created a iatrogenic epithelial defect and discontinuity in another quadrant. We placed those lenticules on that quadrant, and we then went ahead to see the regenerative capacity of that lenticules. We took that cornea when the lenticules was dry. We marked the areas with lenticules, and then we dissected those pieces into 6 to 8 such pieces. We sent those pieces to our oculopathology lab to see how over the weeks these limbal epithelial stem cells are growing and regenerating into the epithelium. These were the samples we sent. To our wonderful surprise, this is on the first post-op week, the first post-op day, the limbal lenticule is sitting over the corneoconjunctival junction. And then post-op week 3, the stem cells from the limbal lenticule has migrated deeper into the corneoconjunctival junction. And by post-op week 6, the lenticules, the stem cells have completely immersed into the deeper stoma, and the haze is completely gone. Thank you.
How many days post-op was this initial haze that you noted in your PK patients?
My first scan was done post-op day week 1, and
Post-PK?
Ma'am, the patients were enrolled with persistent haze for more than 3 months. Then we did the surgery, and then we analyzed for 6 months. First scan was done as post-op week 1.
So, but there was no frank epithelial defect in these patients?
No frank epithelial defect, ma'am. Only micro defects analyzed on AIOS2025.
Okay. Thank you.
Very well presented case. And the next speaker, Dr. Jasra Idris, to speak on delayed IOL exchange, a novel technique.
A very good afternoon to one and all. IOL exchange, a novel technique. A 43-year-old businessman presented to us with diminution of vision in the left eye. He was diagnosed with posterior subcapsular cataract requiring phacoemulsification with intraocular lens implantation. However, the patient demanded that he wants spectacle freedom post the surgery. Thus, all the necessary pre-operative investigations were performed, namely the IOL Master 700 and the eye trace refraction, which showed that the angle kappa, angle alpha and the total corneal aberrations were all within the normal range. Considering that he is a potential candidate, phacoemulsification with trifocal IOL implantation was planned. A thorough pre-operative counseling was done regarding the patient's expectations post-surgery. Post-operatively, even though he had a vision of 6/6 and N6, he was extremely dissatisfied. According to him, his vision was clear for the distance and near, but he was unhappy with the intermediate vision and the range of this intermediate vision. The post-op eye trace refraction was also insignificant, and the patient was not accepting any glasses for distance or near. The patient was counselled to wait and allow for neuroadaptation, as is advocated for the acceptance of trifocal IOLs. However, even after 6 months, the patient was unhappy and wanted a revision surgery. After explaining about all the possible complications, an IOL exchange with an EDOF lens was planned. Intraoperatively, after the clear corneal incisions were made, generous amount of viscoelastic substance was used to separate the anterior capsular rim, the IOL and the posterior capsule from each other. Owing to the fact that 6 months had passed post the trifocal IOL implantation, significant epithelial cell migration had occurred, causing dense adhesions around the two haptics. Multiple careful attempts were made to release the haptics from the surrounding fibrosis. It was a Herculean task. However, the knobs of the haptics were particularly adhered to the capsular bag, causing considerable zonular stress. In an ideal situation, the IOL should have freely rotated in the bag in order to prolapse it into the anterior chamber, which was not the case here. As scary as it looks, a last attempt to release the locked haptics was made, but to no avail. Encircled in this video, we can see a fibrosed tunnel surrounding the knob of the haptic. Hence, a decision to cut the optic in half within the bag using a IOL cutting microscissor was made, disengaging the two haptics from each other. Then, intraocular microforceps was used to pull out each haptic from the fibrosed tunnel. And the two halves of the IOL were removed separately. The trifocal IOL was successfully explanted without compromising on the zonular or capsular bag stability. Following this, an extended depth of focus IOL was placed successfully in the bag. Visco-wash done and the wounds were hydrated. On post-op day 1, the patient had a spectacle-free vision of 6x6 for distance and N8 for near. He was happy with the intermediate vision, the extended range of vision and its quality. It is well established that superposition of focused and unfocused images can cause visual disturbances post-trifocal IOL implantation, which can be troublesome for patients. When IOL explantation is planned after a delayed period of 3 to 6 months, formation of dense fibrosis around the haptics makes the explantation challenging as the bag and the zonular stability can be compromised. This technique of in-the-bag IOL explantation seems to be a promising one in cases where even after waiting for neuroadaptation, the visual disturbances do not decrease and IOL exchange seems to be the only option. The key takeaways from this technique of delayed in-the-bag IOL explantation are disengaging the two locked haptics to allow for easy explantation of the IOL and to rotate out the disengaged haptic from the surrounding fibrosed tunnel to maintain the capsular bag and the zonular stability.
Very nice presentation.
Thank you so much, sir.
But whenever we are doing this procedure, when we have to exchange, what is your opinion? Because he is satisfied, the patient is satisfied with distance vision and near vision. Only intermediate vision is giving him problems. Whereas with EDOF also, it's not that all far distance vision, near and intermediate, all will be good, because intermediate can be better, but near vision is little compromised. So the patient can again say that perhaps he was not counseled earlier that he would require an intermediate vision better, and he can compromise on near vision. That was one question. Second question is that now he has agreed that his intermediate vision is important, and so he would go for even a compromise on the near vision. So this kind of things could be avoided, because surgery, though you have done it very well, it's a very beautiful surgery, but it's not always, easy to manage the whole thing. So it's very important to counsel such patients, particularly when they have good far off vision, good near vision. It's very important and a very important decision to make to remove. Though the technique that you have used here is immaculate, very nice, very wonderfully done. But these are the questions which are always there in the mind. So whenever we are particularly going for a multifocal IOL, we have to ensure, how is the acceptability and what are the terms, because there is nothing as a surprise. If there is a surprise of power, perhaps you would have changed the idea that there is some problem in the power calculation or whatever. But it's all done very well. Just because patients has not understood the whole thing well, that's why the problem is there. But we must admire excellent technique of the surgery and the excellent result that you have got.
Dr. Idrish,
Yes.
very daring surgery. I thank you for that. Patient was lucky and you were also lucky, I think. But when did you felt that the haptics have been disengaged? Because without doing disengaging fully, what was the signs or what was the clue which suggested you that now you can remove this? Because we have been doing these things for several times, but while trying removing this haptic, we have met several times, we have met dialysis of the journey. A lot of things.
Yes. So while we were doing the visco expression, so what happened at that time, so we noted that there was a tunnel kind of a fibrosis which was around the two haptics. So using the visco and a fine iris depositor, we could remove that fibrosis from around the haptics, but the knob was particularly fibrosed. So there was no rotation of the IOL. What happens is the whole IOL had to rotate in the bag in toto, but that was not happening because one was clockwise, one was anti-clockwise. So what we had to do is cut the IOL in half, and then we knew separately we can rotate it out, like one anti-clockwise and one clockwise. So it was only around the knob, and that was easier to do, and that's how we disengaged the two haptics and pulled it out. Because when we were trying to do it without disengaging the haptics, without cutting, we saw, as we saw in the video, there was considerable zonular stress. So knowing that after cutting, hopefully we will be able to remove the whole haptic. The other plan was, if in case after that also the haptic is not disengaging, what can be done is that the haptic would have been left and the optic part would have been cut out. So that was our plan B, but hoping that our plan A works, this is what we did, sir. And thankfully it did work.
Okay. Very nice surgery. Thank you.
Thank you so much.
Yeah, we call upon the next speaker, Dr. Mohiddin Abdul Qadar, to speak on override the giant wave of angle closure, the experience, the new Phaco Plus.
Good afternoon, everyone.
Primary angle closure glaucoma is estimated to affect 15 million people worldwide. It is responsible for 50% of glaucoma blindness. It results from apposition or adhesion of the peripheral iris to the surface of the pigmented trabeculum. The blocking of aqueous access to the trabeculum results in raised intraocular pressure. Acute angle closure glaucoma. It is a true ophthalmic emergency, and a delay in treatment can result in blindness. It accounts for a significant number of glaucoma cases among persons of Eastern Asian and Southeast Asian descent. Some investigators reported beneficial effects of a procedure called goniosynechialysis combined with phacoemulsification to widen the anterior chamber angle, especially in cases of acute primary angle closure with recently formed peripheral anterior synechii. Goniosynechialysis physically separates peripheral anterior synechii, PAS, from the trabecular meshwork using a spatula or microforceps under direct visualization with a gonio lens. So, what exactly is Phaco Plus? In this procedure, goniosynechialysis is combined with phacoemulsification to widen the anterior chamber angle, along with inadvertent goniotomy, with the help of Tonito microhook. Indications include acute primary angle closure, acute on chronic angle closure, primary angle closure, and PACG controlled with medication. The Tonito microhook used for trabeculotomy is a reusable, slender, Sinskey hook-like instrument that comes as straight, left, and right hooks. Surgery in acute angle closure is ridden with challenges, ranging from residual corneal edema, poor dilatation, large lens, weak zonules to floppy iris. We present a case of 70-year-old female who presented with headache and was treated at a local hospital for raised IOP. Examination revealed corneal epithelial edema with fixed, dilated pupil and an IOP of 54 mm mercury in left eye. Patient underwent peripheral iridotomy in both eyes, and IOP came down to 25 mm mercury. The lens was thick in both eyes with 5.10 mm in left eye. Patient was planned for phaco plus. Precautions needs to be taken while performing phaco. Adequate dilatation was obtained using high-density viscoelastics. Hydro procedures need to be gentle. Here a hydrodelineation along with dissection is being done. Perform phacoemulsification using lower parameters to ensure safety. Here a direct chop is being done. Intraocular lens is implanted in the bag. After docking the gonulins, the angle is visualized and goniosynechialysis is done. The peripheral anterior synechii is released gently using Tonito microhook. Then cleavage of the trabecular meshwork is done using Tonito microhook. Trabeculotomy is done in other quadrants as well. Post-op medications included topical steroids, antibiotics, and pilocarpine. At 2 weeks post-op, patient had a vision of 6x6 and IOP of 11 mm mercury. Next patient is a 65-year-old female who had undergone peripheral iridotomy in both eyes. Examination revealed an IOP of 26 mm mercury with grade 4 cataract. Both eyes had short axial length. Central fields were constricted. Patient was planned for phaco plus. In this case, iris hooks were used for obtaining adequate mydriasis. Phacoemulsification was performed with care. A multi-piece intraocular lens was implanted in the bag. This was followed by goniosynechialysis and trabeculotomy using Tonito microhook to complete the phacoplus. At post-op 2 weeks, patient had an IOP of 18 mm mercury without medications. So what is the optimal timing of cataract extraction after an acute attack? 4 to 6 weeks after control is suggested to minimize risks. Studies show that IOP and medications after acute attack can be reduced by phacoemulsification, and lowering of IOP was found to correlate with lens thickness. Also, phacoemulsification combined with goniosynechialysis was effective in both acute and chronic angle closure glaucoma. However, reformation of peripheral anterior synechiae was common in chronic cases. Prerequisites for phacoplus include Swan-Jacob gonulins, Tonito microhook. Keep phaco parameters low. High-density viscoelastics should be used for docking and maintaining the anterior chamber. The authors have no financial interests in the products shown. There are multiple mechanisms for IOP reduction. It can be due to improved outflow due to deepening of anterior chamber, phacoemulsification-induced stress remodeling from ultrasonic vibration, surgical trauma-induced prostaglandin release, which increased uveoscleral outflow, and high fluidics during phacoforces fluid through the trabecular meshwork into the canal of Schlemm, which may increase patency and promote flow. Thus, the technique of phacoplus deepens the anterior chamber block and reopens the natural aqueous pathway. The advantages include early visual recovery, good near vision, and avoiding complications of trabeculectomy. This simple technique is a boon to surgeons and patients, like the sunshine through the dense forest.
Very nice, informative video, and definitely in angle closure glaucoma, along with cataract, it's very important to take a decision when to operate, how much time to wait, how much time you spend on controlling pressure, and particularly when you are using the technique that you have showed wonderfully, the results have been excellent. But you have to have a proper setup with all instrumentation and all these adhesions, the PAS has to be carefully, the work has to be done very, very meticulously, otherwise there are a lot of complications that can happen. So it's a very beautiful video that you have presented and very, very scientific. Wonderful, wonderful work. Yes. Yeah. So we go on to the next talk, next video, transformative journey of capsular tear. Yeah, he's not there. But he was there? No, he's not. All right.
Dr. Tushya Om Prakash?
Dr. Tushya is there?
No, okay. We can proceed, sir. Ahead.
So we have Dr. Pooja Kamar to speak on revolutionizing vision, the peel approach to corneal surgery excellence. Dr. Pooja.
Thank you, sir.
Yeah.
At the outset, none of the authors have any financial disclosures for the video being presented.
In our fast-paced, technology-driven world, myopia is becoming increasingly prevalent. According to global data, the prevalence of myopia has doubled in the last few decades, and it's estimated by 2050, nearly 5 billion people around the world will be affected. As myopia rates increase, so does the need for refractive surgery, as it reduces dependence on glasses or contact lenses. Corneal refractive surgery has undergone significant evolution, improving its effectiveness and safety over the years. Today's young patients are notably well informed with widespread access to digital information regarding laser-based vision correction. They expect higher precision, safety, and outcomes from modern vision correction technologies. In summary, the evolution of refractive surgery reflects ongoing advancements aiming to enhance precision, reduce recovery times, and improve patient outcomes. Refractive surgeons commonly face several fears and concerns. They worry about plane identification, tougher dissection, and retained lenticules, which can affect the outcome of the surgery. But the connection amid these fears is the way lenticule is dissected and extracted. We know that more tissue manipulation leads to subclinical edema, affecting the quality of vision post-operatively. So we took a look at advanced corneal refractive surgery platforms and observed that they differ in their specific laser parameters and applications. So we decided to use this advancement in technology to patients' advantage to provide enhanced quality of vision. We first hold the lenticule gently with the forceps and exert traction radially to pull the lenticule from the surrounding stroma. But not just that, we also wanted to see if this technique is better than the conventional dissection technique. We found that patients had better quality of vision, as we can see through the objective scatter index and also through better point spread function. This technique is repeatable and more reassuring for the surgeon.
It's a very interesting observation and a very interesting presentation. It's done absolutely beautifully, like in a Bollywood style, the way you have, demonstrated finesse of the surgical procedure. So, which are the machine? When was the machine introduced, and which other centers are having the same way they are managing, and what have been their results in India or internationally? What are your common observations on these? What are the scientific data that are available?
So as we all are aware, lenticle surgery has been there for more than 10 to 15 years now. Professor Sri Ganesh has tried this technique of removing the lenticle like a forceps with SMILE. But as you saw in the video, the difference in SMILE and silk is the spots are not next to each other. So you technically are doing a schisis. You have to separate the lenticle by dissecting, which may create some amount of subclinical edema. Silk has been there for almost 5 years. We've started using it from 2020, and commercially it's been available since 2022, and now there are 25 installations. And the difference with silk is the spots are next to each other, so technically it's all separated. You don't have to go ahead and dissect it and separate the tissue bridges which are between the two spots. So that's when we thought that because the laser spots are next to each other, every surgeon for many years have been having, a lot of surgeons have the dread of dissecting the lenticle, the remnants of the lenticle or a torn lenticle. Because in silk there is no spot distance between two spots, can we just do like a rhexis, like how it's in flax? So we've been doing this technique for almost 2 years now with 1,000 eyes, and we've only had less than 5 eyes where we had a small remnant of lenticle in the periphery, but otherwise all the lenticles were removed in toto. How many have started replicating this technique is, silk is kind of a new technique, so everybody is just getting into doing the peel way of removing the lenticle, and as far as I know, almost 7 out of 25 surgeons have started adopting this, because many are new lenticle users, and for every new user, I myself would suggest that we first do dissection, master it, and then go to peel. So 7 out of 25 surgeons in India have started doing it.
Because there are a lot of new machines, newer technologies, and if you see the commercial way these centers present themselves as if they have a miracle cure of myopia with the latest technology.
So there is no miracle cure.
There are a lot of technologies available even with Alzheimer and even with lenticle. Definitely as scientists, as ophthalmologists, we understand that with lenticle, the dry eye syndrome and the dryness, which is main concern, is eliminated to a great extent. And also, but the wow effect, how do you find the wow effect compared to other forms, and how do you consider with the, are you aware of the Smile Pro and other machines which are available? How do you compare them?
Yes, sir. We've personally have an experience with Visumax, Smile Pro, Schwind, AIOS and Silk, 3 of them out of the 4 technologies available. I definitely, working with lenticle procedures and doing a PhD, what we have understood is more you dissect or tougher your dissection is, day one the patients may have 20/20 or 20/40 vision, but the quality and the wow effect will not be there. So the whole idea to try to introduce this technique for everybody to use as we move on is because we have proven that minimal the dissection, the day one outcome is going to be better, and at least 97 to 98% patients can have 20/20 wow vision with lenticle procedures like you do in LASIK. So that is what we aim to do. The biggest challenge why every technology we cannot do a peel technique right now is because of the spot separation is separate in all the techniques. Every machine has a different energy, every machine has a different spot separation and the different shape of lenticle. This can be replicated for all the techniques, but once you modulate the energies in the right way. So this would be the way forward, but it will take time, like how we evolve in phaco and IOLs. This will be the same process of evolution.
How do you find if the patient moves eyes and suppose you have to stop the surgery in between, can you restart at the same plane, or any observation on those things?
In silk,
yes.
In silk procedure, sir?
Yes, yes.
At this point of time, the technology from the company perspective, they do not have a rescue mission. But we've had 1 or 2 cases of suction loss in the past 5 years. And what we have done is we've done an OCT after the OBL has disappeared and see how much the plane is created. And if there is not much of, if the anterior plane is not created, then we go ahead and redo the surgery with silk procedure at a deeper plane, maybe 20 microns deeper, and we've been able to redo it. And we've removed the lenticle successfully in those patients. But they need to come with rescue missions for silk technique.
Your presentation have been excellent, and perhaps we come to a consensus by all ophthalmologists in the country that this is the ultimate, whatever is the ultimate procedure. So that will be a very important piece of information to all of us, because in every case of myopia, which is otherwise a normal eye, we would not like to compromise on vision aspect, absolutely. So this is very important that as best as possible, the vision we have to restore to the patient in a myopia. So your presentation have been excellent. Yes, Dr. Shikha would like to add something.
Yes, sir. Thank you, sir.
Thank you, Dr. Pooja. That was a very, very nice presentation. So do you do any change in settings of your machine when you do go for a dissection or a peel mode?
Ma'am, now not. So initially when any machine comes into your hands, like in LASIK there were nomograms. A lot of surgeons work on nomograms to have plano 20/20 vision the next day. In SMILE or any lenticle procedures, whenever a machine comes into your hand, the first step is energy optimization. So hence, when you are energy optimizing for any laser, you should dissect and first master it. Once you are comfortable with your energies, then you can go ahead and do the peel technique. And once you have optimized the energies, then you don't have to really change it between dissection and peel. So it can be same for both the procedures, and I don't go ahead and change for a particular, oh, I am going to dissect this, I'll put this energies, I'm going to peel here, I'm going to use the second set of energies. It's the same for all patients. But it took more than, so this is 1,000 eyes, but we took another 500 eyes before this to energy optimize it.
Thank you.
Thank you.
Dr. Pooja, it was your video was where the science meets cinema. It was a very excellent presentation.
Thank you, sir.
And very informative also. One thing you just explained to Dr. Pooja that you do energy optimization because you are using more laser as compared to other machines.
Yes, sir.
Does it have any long-term or immediate effect because of laser energy over the cornea?
Sir, so with no financial interest, when the technology came in, they said it's a very low energy laser, and that's why it's safer. But if you see the cumulative energy, because the spots are more, the cumulative energy is more. So whenever the cumulative energy is more, the biggest fear is that it may cause haze or subclinical scarring. So that's why you saw a lot of confocal images in the video. When we don't see any clinical scarring, but to address the subclinical scarring, whether the high energy, the cumulative high energy is causing any damage or not, we looked at keratocytes and myofibroblasts, and we quantified it between SMILE, AIOS, and silk, and it's been similar for all the lasers. So we don't know why, but such a high cumulative energy is not causing any damage to the wound healing or the cornea itself.
Nature is very resilient.
Yes, sir. It's a scary thing. We also had a scare that it may cause haze, but the confocal doesn't show that.
Yes, your presentation has been excellent, and the way you have presented, you have actually, made us to believe that this is going to be the ultimate. Thank you very much.
Thank you, sir.
And with this, we mark the end of this session, and we are very delighted to have wonderful speakers who have been speaking and who have been showing one of the finest videos of international standard here. And we would like to have a photo session with all our speakers who have presented in this session. We would like them to come onto the dais and have a photo session with the panelists. got the ability